So today's teaching is on computerized CTG and the Dawes-Redman analysis. The outline of this teaching will be a look at the physiology of the fetus, trying to understand the components of the analysis, and whether computerized CTG is superior to visual CTG, who needs a computerized CTG, and interpretation of the CTG report. And we'll look at a couple of case studies. So first, a look at the physiology. So in looking at the physiology, we'll need to look at the fetal oxygenation, fetal response to hypoxia, fetal sleep-wake cycles, and try to understand how all of that fits into the CTG. So we know that the fetus has two umbilical arteries that pump deoxygenated blood from the fetus, and one umbilical vein that's pumping oxygenated blood. We also know that the fetus isn't using its lungs, and it only uses lungs once it's out of its mother. So whilst it's inside the mother, the lungs are not functional, and the fetal lung, in quotes, is the placenta. So the fetus is different from the adult in this respect. When the adult is hypoxic, it can increase its rate of breathing. The adult can breathe faster and can breathe deeper to increase its oxygen. The fetus does not have that capacity, and the fetus does not control blood flow to the placenta. So the fetus has to adapt differently to be able to survive in its environment. Again, looking into fetal oxygenation, we know that oxygen transfer occurs across the placenta, and the fetus uses the oxygen in the metabolism of glucose. So once there's oxygen, aerobic metabolism takes place that releases carbon dioxide and water, which is taken back across the way. The baby is adapted to its environment. Now, it lives in a relatively hypoxic environment, which is about 70% what the normal oxygen saturation is. And this even decreases further to 30% when in labor. So some of the changes that the fetus makes includes an increased hemoglobin. So with more hemoglobin, it has more oxygen carrying capacity. The fetus also has hemoglobin F, which is different from the adult hemoglobin A. And this hemoglobin has a higher affinity for oxygen. The baby can also release oxygen at lower oxygen tensions. The other feature that the baby has is his heart rate. Because it's beaten at a higher heart rate than the adult heart rate, what the advantage it has is that it can do more circulations per minute compared to adult human being. It also has these shunts, ductus arteriosus, the foramen ovale, the ductus venosus, and the arteriosus, for instance, shunts blood away from non-functioning lung. So when you take all these adaptations together, it allows the baby to live in the environment in which it finds itself. Now, what happens when oxygen is disrupted? You initially will have hypoxemia, where there's a reduction of oxygen content of the blood. The PO2 in the blood is reduced. And if this progresses for a long time, you have hypoxia, which is reduced oxygenation in the tissue. And this is usually accompanied by pH changes and lactate accumulation. There are various ways in which oxygen is disrupted. It can be an acute hypoxic event or a chronic hypoxic event. So some of the acute hypoxic events are like cord compressions and uterine compressions. And these are very typical in labor. But the chronic hypoxic event, which normally are the commonest events that we'll see antenatally, include anemia and placental malperfusion. So you know that our placentation occurs in two ways. So issues with placental malperfusion occurs in two ways. There's the first one where the placental trophoblastic invasion itself doesn't occur appropriately. So we generally have a high caliber spiral arteriole, which upon trophoblastic invasion becomes a low caliber, more compliant arteriole, and that can easily send blood to the baby. Now, if the first wave, which is in the first trimester, and the second wave, 16 weeks, does not occur properly, what you have is still a high caliber, high pressure system, which impairs blood flow to the baby. And we can see this one now. Uterine artery, mid-trimester, uterine artery, and PIs. And subsequently, you see the manifestations in like artery, PIs, and blood flow. So that's the first. The second way is when the placenta becomes too old in post state, and also when the placenta, the baby is too big for the placenta to function. In all these cases, you have a relative uteroplacental malperfusion. So essentially, this is what we would normally see, and we see the manifestations of chronic hypoxia more during the antenatal period. And when the adult is exposed to these hypoxic changes, it will increase the rate of death of its respiration to maintain a positive balance. The fetus, on the other hand, cannot do that, so it has to slow down its heart rates to protect its myocardium and maintain a positive balance. When the lung function in codes of the placenta is disrupted, what happens? So oxygen is no longer coming, and the CO2 produced from the aerobic metabolism of the oxygen cannot go out. So when you have accumulation of CO2, you have a high PCO2 and a low pH and develop respiratory acidemia. And if this goes on for a while, the baby has to adapt to this. So it reduces oxygen consumption and becomes more energy efficient by doing things like reducing movement and stuff. Then it will switch to anaerobic metabolism, produces lactic acid. There will be a falling pH, a large base deficit, and move to metabolic acidemia. The pH, lack of oxygen, lactic acid are toxic to the baby. So how do babies respond to acute hypoxic events? They reduce their heart rates, they stop breathing movements, and they reduce their oxygen consumption, and they try and maintain cardiac outputs by reducing their heart rates. And most of these changes will be mediated by chemo and baroreceptors. And we see a lot of these changes as a deceleration on the trace. When the insult continues for a long time, then you have glucose restriction, essentially baby slowing down its growth to conserve energy, slowing down its movement to conserve energy, cutting down blood supply from non-essential organs. So as far as the baby is concerned, kidney, gut, and skin are non-essential. The brain, adrenals, and the heart are essential organs. So what baby does is shunts blood away. So you will see a redistribution on the cerebral artery flow, and when the baby is shunting blood away from these non-essential organs to the brain. And you see oligohydramnios, for instance, when blood is shunted away from the kidneys, and these babies will sometimes be born with ashen skin. And also, when you shunt blood away from the guts, is an increased risk of hypoxia to the guts and loss of sphincter tone and cranial passage. Now, when the baby has been hypoxic for a long time, it doesn't even have the strength to mount a decelerative response, and therefore you see a blunted response and a shallow deceleration. So that is all about oxygenation and the baby's response to oxygenation and the physiology of why that is happening, and how we see it as decelerations on the CTG trace. And we also know that the baby's heart rate is controlled centrally from the brain. And we know that the central nervous system coordinates all of this and also coordinates integrated behavioral changes. Now, central nervous stimulus produces accelerations and also produces fetal movements. Now, we've traditionally been taught that accelerations are a result of fetal movement, but actually research has shown that we can still see accelerations in anesthetized babies who are not moving. So accelerations are not really the sense of it from fetal movement. Accelerations come from the same place where fetal movements come from the brain. So the brain gives a stimulus that shows a complex integration within the brain that causes us to see an acceleration in the CTG. But that same stimulus can also cause fetal movements. But those two are not dependent on each other, and therefore you can see accelerations without fetal movement. And that's why we can see accelerations in babies who are anesthetized. Again, the autonomic nervous system controls the baseline heart rate and the variability, and the parasympathetic nervous system, working through baroreceptor receptors, can slow down the heart rate in response to a muscle stress. So the baroreceptors are located around the aortic, the carotid sinus. And what happens is that when there's any occlusion or an increase in the blood pressure of the baby. The signal goes through them. The vagus nerve is activated. It comes round down to the SA node, slows the heart. And then once the pressure is gone, you quickly see a rise back. You typically will see this from cord compression from reduced LIGO antenatally. You normally do not see uterine contractions antenatally. Therefore, you will not really be expecting variable decelerations, which are cord compressing decelerations that we see in intrapartum. Again, when you switch from aerobic to anaerobic metabolism and start building H plus and lactic acid, you stimulate the carotid body and aortic bodies. And these are chemoreceptors that will again stimulate the vagus nerve and slow down the SA node and slow down the heart. A recovery of these may take longer because you need to physically wash away these acids in order to relieve the stimulus and therefore come back to baseline. Again, like I said, the brain, heart, and adrenals, when the baby is hypoxic, the baby increases its heart rate. So for the same amount of oxygen, if it's doing multiple rounds and beating faster, it can somehow come back to normoxia in a hypoxic position. So that's an adaptation where there's a catecholamine surge in a hypoxic baby to try and centralize blood, and then come back to central normoxia. Thinking about CNS integration as well, apart from the CNS control of the heart rate and centralization of blood, and baby also to integrated CNS pathways goes through various states. So it goes through 4 behavioral states. One of them, the 3F states, is debatable. But generally, we see the baby in quiet sleep where there's reduced variability and very little activity. Active sleep where you see accelerations, clusters of movement and variability. And awake state where there's vigorous movement and cannot even tell the baseline of the CTG. For us to analyze, one of the mainstays for antenatal monitoring is actually the baby in the active sleep state, because that is the point where we can assess the CTG. In the awake state, it's even difficult to tell a baseline. And like I said, in acute hypoxia, there's increased variability, so you have to be careful in awake state. But the baby generally spends a lot of time in active sleep. And at that point, you can see a clear baseline, you can see acceleration. And this is what we call a computerized CTG, an episode of high theta acceleration. There are also periods of quiet sleep where it has decreased. But it's difficult to assess the baby in quiet sleep because you do not know if this is a physiological quiet sleep or the baby is hypoxic. So generally, the mainstay of antenatal CTG is catching the baby when it's in active sleep when there are episodes of high variation. And in that episode, you see accelerations and you see baseline variability. Healthy babies cycle between active and quiet sleep, usually about 1 to 3 times per hour term. Now, as the babies grow, we spend their time in quiet sleep and active sleep. One of the key features that we realize is that before 26 weeks, from 24 weeks, so earlier than that, the system hasn't developed yet. Babies, it's difficult to analyze a CTG when the baby is not going to episodes of active sleep or going to episodes of high variation. Therefore, if you did a computerized CTG very early or less than 26 weeks, all the CTGs will not meet criteria because there will be no episodes of high variation or no episodes of active sleep, because it's at this point really that you can analyze the baby and confirm that the baby is healthy. So the whole point of the CTG is to test the baby's brain. The baby is going through episodes of high variation or episodes of active sleep where there's good variability, where the CNS gives us stimuli that can produce accelerations. We can say that the baby is okay. When the baby is in quiet sleep, it's okay. So if the baby wakes up and see accelerations together, say that it's a very active CTG and it's awake. So in antenatal CTG, you do not have contractions. You're monitoring the fetal behavioral states and waiting for an episode of high variation. You're also waiting for the CNS effects and for accelerations, the trace. You cannot distinguish between normal physiology and fetal compromise during quiet sleep or episodes of variation. So that is basically that. Now let's understand the components of the analysis. So the first thing you need to understand is that the Dawes-Redman analysis is proprietary. and therefore it's owned by Huntley, and we may not know all the details of what goes on in there. This work is from reverse engineering by some computer analysts try and understand what the analysis may be. So from some of the lectures given by Professor Christopher Redman himself. So the first thing that happens with the analysis is to process the data. So what happens is that the raw ultrasound signal has a lot of noise because it's a lot of noise from maternal movements, the probe around the tongue, other blood vessels, bowel movements, they all produce a lot of noise in the analysis. And all of these noises are often out of range. So what the analysis does is to average out the analysis, remove outliers and filter the signal to get a good signal. And then it analyzes it in epochs of, so every minute is divided into 16 bits, and then it analyzes the 3.75 second epochs. After this analysis, Dr. Redman then does various estimations. So it determines accelerations, decelerations, determine baseline and weapons that we'll talk about. So this is an example of the original trace with all the noise. Sometimes there are bits of loss of signal, but when we look at it visually, we cannot tell, but the computer can tell and average these out. If the signal loss is too significant, then the analysis doesn't happen. So we need at least an 80% quality signal for the analysis to go on. So it averages it out, smoothens it out, and tries to determine a baseline. Goes through a complex algorithm to determine the baseline to the frequency distribution, puts all the baseline calculations in a histogram, and goes through an iteration to determine the best possible baseline. Based on the determination of this baseline, it makes an analysis to determine an acceleration. So the analysis looks at two types of accelerations. Accelerations about 10, accelerations about 50. So the light gray areas are accelerations about 15, and accelerations about 10. And it incorporates this into the analysis to make a determination of whether the baby is okay or not. Again, when we look at visual CTG, we very much have to depend on accelerations. But Dr. Redman knows from the analysis and the physiology that accelerations and episodes of high variation come from the same place, and they both confirm that the baby is okay. So once you have an episode of high variation, you can say the baby is okay, because 40% of antenatal traces where the baby is normal do not have accelerations. And therefore, the good thing about Dr. Redman is it can tell that the baby is okay before we can tell if you are waiting for accelerations. The calculation of decelerations is based on lost beats. So a deceleration is classified as lost beats, so 10 beats per minute for at least 60 seconds, or 20 beats per minute for at least 30 seconds. So if you look at this analysis, if the heart rate was at 140 for the 3 minutes, the number of beats would be 140 for 3 minutes. However, if the heart rate drops to 120, then for those 3 minutes, the number of beats was 120 for 3 minutes. So if you subtract the two, then you know that you lost 60 beats. And it is this lost beats that Dr. Redman uses to calculate decelerations. So there are three categories of decelerations. You have small, medium, and large decelerations. Decelerations that constitute lost beats less than 20 beats are often disregarded by the analysis. When you have medium deceleration between 21 and 100 lost beats, then or large decelerations, those are very important and they are factored into the analysis. The next thing that the computer determines is long-term variation. So heart rate variation refers to the deviation or oscillations of the heart rate above the baseline, or we normally call the variability. So babies go between active sleep and quiet sleep. And in active sleep, that's where we primarily assess fetal well-being, because we can see acceleration, clusters of movement, and episodes of high variation. But in quiet sleep, assessment of fetal well-being is impossible because we cannot tell if the baby is hypoxic or just going through an episode of low variation. So if you begin monitoring an episode of low variation, you must continue to a period of high variation before you can actually say that the baby is okay. And that will require some time, because babies can sleep for up to about 15 minutes at a time. And you realize that very early preterm labor, you don't normally have a lot of high episodes, and therefore virtually all these traces will not have high variation. So generally, when you are calculating long-term variation, you are looking at these excursions over the entire trace. You are trying to do that over the whole trace because the baby goes through episodes of low and high variation. So how do we calculate the long-term variation? So we calculate the maximum excursion from the baseline minus the minimum excursion from the baseline for every minute, which is called the minute range. And then you cumulatively find the mean of all the minute ranges to calculate the long-term variation across the entire trace. So you see that within the long-term variation, there'll be episodes of high variation and there'll be episodes of low variation. And what you do is you look at I looked at a database of over 300, 150,000 to 300, and tries to create a normal distribution of long-term variation. So you want the baby's long-term variation to fall within the normal distribution. And if the baby's long-term variation is an outlier, so if it's less than the third centile, less than the 10th centile, and outside 3 standard deviation, then it's not within acceptable limits. So it means that it's quite low, and therefore the mean long-term variation didn't really have a lot of high episodes in it, and that's why it's quite low. So you need to continue the analysis because you're not really sure the baby woke up in that analysis. Again, there's a short-term variation, which is a measure of how fast the baby's heart rate is changing from epoch to epoch. So what we mean is in the analysis for every minute, Dos Redman has divided every minute into 16. So that means that every minute has 16 calculations of heart rate changes. And this is at 3.75 second epoch. So one epoch minus the other epoch, then it does the analysis, and the next epoch minus the other epoch, and then it does 16 of these calculations within a minute. And based on that, it does this calculation for 1 minute, and then it does it across the entire trace to find the STV, how quickly the heart rate is changing from one 3.7 second cycle to another 3.7 second cycle. And that is why this is something we cannot see on the trace because it's a calculated variable. It's an objective variable of the rate of change of the baby's heart rate. Why is this important? Because the STV is a predictor of fetal acidemia and hypoxia, and a reduced XCV is a predictor of fetal acidemia. When you look at this paper by Sarah et al., you realize that as the STV drops to less than 4, the likelihood ratio of fetal acidemia shoots up significantly. As it approaches 1, the likelihood ratio goes above 5 towards 10. So you see that, for example, as the STV is less than 3, the likelihood ratio is 5.2. So a low STV, if the rate of change is low, then the risk of acidemia is high. And this can only be calculated. But what is calculated is validated over 60 minutes. And therefore, for every epoch to epoch, an STV is calculated. It's summarized over 1 minute and then summarized over 60 minutes. The validated value is a 60-minute value, which was used in the travel study. And that is what, if you do not meet criteria at 60 minutes, you look at the STV. And if it's low, you need to take action. Generally, an STV does not fall consent. And then it determines the baseline. You don't want a bradycardia because you know that is an acute event. And you also don't want a sinusoidal rhythm. Based on analysis, I can tell a sinusoidal rhythm because it's associated with fetal anemia. So after putting all of that together, it goes through an iteration. So the iteration says that as a recording, as the one episode of high variation. So has the baby woken up? If it has woken up, is STV greater than 3? So is the risk of acidemia low? If it's low, the STV is lower than 4.5. Is the LTV okay? Because the LTV in episodes of high variation has to be within standard deviation. And then you also need to make sure you don't have high frequency sinusoidal waves to make sure the baby is accelerating. You are not having any large deceleration. So it goes through this iteration. And once you meet a certain number of iterations, the trace is approved. The first iteration is done at 10 minutes, and then again every 2 minutes. So the criteria of normality, you must have at least 1 episode of high variation. You do not want fetal anemia. So high frequency sinusoidal wave should be out. So you should have a normal STV and LTV, accelerations present, fetal movements present, no large or repeated decelerations, normal heart rate, and good trace quality. So that is how the analysis is done. Once you understand the analysis, you can use it and interpret it. Now, is computerized CTG better than visual CTG? The answer is no. When you look at this forest plot, and when you're looking at the forest plot, you have to look at the heterogeneity and also look at the diamond, whether it's causing one, because for any odds ratio that involves one, there's really no difference between the two interventions. But when you look at all-cause mortality and preventable mortality, the diamond is sitting on one. So there's really no difference between, even though it favors computerized CTG, there's really no difference between the two in terms of sectioning up the score. So essentially, there's no significant difference between computerized CTG and visual CTG in terms of all-cause mortality and stillbirth. However, we know that computerized CTG is objective because it's objectively calculates an STV, which you cannot calculate in visual CTG. So that's an objective measure, which is a predictor of fetal acidemia. We also know that the output of computerized CTG is more reproducible. And from the Saving Babies Live version 3 manual, we realized that a lot of the stillbirth was due to CTG misinterpretation. So having the computerized CTG becomes the most experienced person to look at the trace again if it says the criteria has not been met, and potentially also reduces the time because you are not really waiting for a long time once criteria is met, and criteria can be met as quickly as 10 minutes. So it's an objective tool that can be used. Who needs a CTG? And we only do CTGs in high-risk pregnancies. We will not really do CTGs in low-risk pregnancies because it's not validated. It just increases interventions. So interpreting the CTG report, once you start the analysis, for the first 10 minutes, the indicator will be light purple. And then from 10 to 60 minutes, when criteria has not yet been met, turns dark purple. Once criteria is met, it turns green on the machine. And if at 60 minutes not met, it's a light blue. Find out why. So generally, you can see all the features we've been talking about. The heart rate, you can see the two types of accelerations. You can see the significant decelerations, the medium and large ones. You can see high episodes. So criteria was met here because we had 10 recorded episodes of high variation. So baby was awake and active sleep. And STV's criteria has been met in this instance. In this instance, criteria has not been met because you can see that when you go to the high episode, there's zero. There's no high episodes at all. And you can also see that there are some decelerations, but these were not mentioned because they are not significant decelerations. They were less than 20 lost beats, so they are not significant. So the reason why criteria is not met is because there are no episodes of high variation. So what are the 4 outputs from the Dawes-Fedman? Criteria can be met and can be met very quickly within 10 minutes. And once it's met, you look at the trace and make sure you're happy with the visual assessment of the trace, and then continue with care. Sometimes criteria is not met after 60 minutes, but the STV is normal. In that case, you need to understand why criteria has not been met and make a decision based on that. There are various reasons why criteria is not met, some of them more serious than others. These are the 12 codes why criteria is not met. And understanding why criteria is not met will allow you to decide what to do next in the context of the clinical situation you find yourself in. Now, when criteria is not met and STV is low, then you have an abnormal situation with risk of hypoxia and acidemia, and you need to consider immediate delivery. So generally, any STV less than 4, or typically 4.5, is a problem. There's a risk of acidemia with that, and you need to consider delivery with that. So generally, based on the truffle study where they used 3 groups, the STV in each of the groups was the fail-safe in determining delivery along with spontaneous repeated decelerations and A wave. So in FGR babies, for instance, using the STV as and the date, that is venosus A wave being absent, are endpoints for delivery. And so STV is very important. If you have a clearly abnormal antenatal CTG, then you need to plan delivery. What to do when criteria has not been met? When criteria has not been met, you need to understand why criteria has not been met and take a decision based on that. So understanding what to do is like doing a full blood count. So generally, when you do a full blood count, you interpret and take your decision based on the clinical context in which the full blood count was done. Why did the full blood count? The index is not a full blood count. So for instance, the patient came with an HB of 12, needed a cesarean section, and afterwards in recovery, you repeated the HB and it was 5, and the tummy was tense. Your treatment for that is to go back to theater, open the tummy up, stop the bleeding, and transfuse. For another woman who's having heavy menstrual bleeding and who comes in with the HB of 5, you not send her to theater to open her tummy up. You just transfuse her if she's symptomatic. Again, for a woman with a hemoglobin, let's say of 9, who has low ferritin, you want to give an iron infusion. For the same hemoglobin, for a woman who have a high MCV and MCH, you want to give folic acid or vitamin B12. So what you do for hemoglobin depends on the context. You do not commit to the same action for every hemoglobin. So it's the same with the Doss-Redman when the criteria is not met. The first question should be, what is the reason for criteria not meeting? Why was the trace done anyway? What is the gestational age? Are there any maternal or fetal complications? And this is the first one of a series. You need to understand that, like the HB, your HB itself is not a diagnosis. It tells you what the HB is, and you need to find out why the HB is like that. It's the same way with the Doss-Redman. It is not a diagnosis. So what you do is determined by the context. Some of the reasons why you have your criteria is not met, one of them is large decelerations. Now, from how large decelerations are calculated, they are calculated from loss speeds. So, for instance, if your criteria is not met and you see 2 large decelerations as a reason why your criteria is not met, and you look at your trace and you have 2 areas of loss of contact, you instinctively should understand that criteria has not been met because of those areas of loss of contact. And therefore, you can just repeat the trace and make sure you have contact and criteria will be met. If you have an isolated large deceleration, you probably want to rule out oligohydramnios, for instance, as a reason why you're having that isolated large deceleration. But obviously, if you're having recurrent large decelerations, then you obviously have an abnormal trace in front of you and you want to expedite delivery. If the reason criteria is not met, is no episodes of higher variation, then the question is, this baby is not coming into active fetal sleep cycles. It's just in quiet sleep. You have to ask yourself, why is this happening? If the STV is normal and visual CTG is normal, then it's unlikely that there is hypoxia, for instance. But you need to still think about why the baby is not going through sleep-wake cycles. For instance, if the baby is so premature, then it's that system hasn't developed yet. We know that in 20% of type 1 diabetics, there's no episode of higher variation because of delay in autonomic nervous system, and there's no difference in outcome for these women. Try to understand the context of why it is being done is very important. If you have a patient with PPROM and neuroinflammation, for instance, can knock off the CNS cycling potential, and therefore you have no episodes of high variation. So try and understand why you're not having episodes of high variation. If you're not having movements, then you have to rule out hypoxia. If the baseline is outside the normal range, you need to think about why that is happening. For instance, if you have an extreme preterm baby whose baseline is sitting about 105, you need to question yourself and be talking to your consultant and try to understand, is there a congenital heart block, for instance? If the baseline fitting is uncertain, but all other parameters are normal, you can ignore this reasoning for criteria not met. High frequency sinusoidal rhythm is when there's severe fetal anemia or severe prolonged hypoxia. When you see this, there's a risk of poor outcome and you need to expedite delivery. So let's look at a couple of cases. So 30-year-old girl with a 2-1 or 36 and 2 presents with itching of the palms, soles, and reduced fetal movements, no rush, bowel assess 300. CTG is done, criteria met at 12 minutes. All the features are okay. So what do you do? And this is where context matters. You know that patients with obstetric cholestasis, CTG monitoring but its health profile does not predict stillbirth. The important predictor of stillbirth is the bile acid level, and bile acid level above 100 increases the risk of stillbirth by about 3.44%. How babies die from obstetrical stasis is through vasospasms and fetal arrhythmia. So your CTG will not be able to predict that. And therefore, in this context, even though criteria has been met, your bile acid is sitting at 300, the recommendation is to plan delivery. So you plan delivery. Again, if you saw a woman with type 1 diabetes with sugars all over the place, on CTG meets criteria, and she's around 36, 37 weeks, and the sugar control has been difficult the whole time, you should understand the context that the most important predictor for this woman is the sugar control size of baby than CTG. So again, another patient, 30-year-old gravid parasero at 35 weeks, green pathway attends with first episode of reduced fetal movements. Criteria met at 10 minutes. CTG visually looks okay. What do? You follow a normal guideline. You plan a scan for her if she hasn't had one in 3 weeks and she has risk factors, other risk factors in this pregnancy. But you realize how things are different for a patient with obstetrical stasis and this patient. In one, you're planning delivery for criteria met. In another one, you are just planning a scan. So what you do depends on the context. 20-year-old gravid parasero at 30 plus 3, BMI 34. Attends with first episode of reduced fetal movement after midnight. Initial CTG variability is not great. Query some accelerations. Maybe abnormal, query 1 deceleration. So I'd say abnormal trace. Somebody may be very optimistic and say the acceleration, so call it normal. However, criteria is not met. STV is less than 4, no episodes of high variation, long-term variation, below acceptable limits. What do you do with this patient? So a couple of things. Visual CTG probably abnormal. Those Redman criteria not met. STV less than 4, no episodes of high variation. So this baby is not waking up from quiet sleep. STV is less than 4, risk of acidemia. Visual CTG is not okay. So probably hypoxia, some growth restriction. What is your plan for this woman? In real life, they repeated the CTG in 4 hours. Again, it's an abnormal CTG. Again, criteria not met for the same reasons. STV is a bit higher now. What will you do? In real life, they repeat it again. And now there are decelerations on the trace. So this is more concerning. So criteria not met, STV less than 4, no episodes of high variation, large decelerations. So try and understand STV less than 4, hypoxia, baby is not cycling. Is there CNS hypoxia? Reduced fetal movement from the physiology, hypoxia. Visual CTG, deceleration, reduced viability, again, hypoxia. So everything is telling you that this baby is hypoxic. So what happened is they did a scan eventually in the morning. The baby was very good, restricted less than the first centile, oligohydramnios, absent and diastolic flow. So again, now everything makes sense from the presentation to the CTG assessment to what Dr. Redman was telling you. And then CTG progressed to obvious deceleration and baby was delivered. And you have a 20-year-old gravid parasero at 30 plus 3, reduced fetal movement. Again, somebody may say the CTG is okay, good variability accelerations, but Dr. Redman tells you, no, there's high frequency sinusoidal rhythm. So again, Dr. Redman gets you to go and look at the trace again and think about the presentation, why this is happening. So here, do MCA PSV, for instance, to confirm, and its baby was born with anemia. The question is this a chronic anemia or acute anemia? Do you want to transfuse, or you need to do a cut? All of that has to go into the thinking and the analysis. Thank you very much for your time.